you for asking me to speak today. At the end of Jonathan's talk, he mentioned that trapezectomy was the gold standard, but also mentioned that he does not use it for his younger, higher demand patients. I completely agree with this. I think it does give most patients a reliable outcome, but recovery is prolonged, grip strength is often compromised, and the thumb never feels normal. I'd like to start with a case. This is a colleague of mine, 42-year-old consultant anaesthetist in our hospital, referred to me as conservative treatments are now not effective and he's struggling to walk. So what surgical options do we have? Well, the classic options for any joint. And in this talk, I'm going to concentrate just on arthroplasty and arthrodesis. So what are the advantages of arthroplasty? Well, it gives you good movement, often normal or near normal, much faster recovery than trapezectomy. It gives you good grip strength and function, again, often normal or near normal. There is some suggestion in the literature that restoring the height of the metacarpal actually improves MP joint hyperextension, and many patients tell us that they have a completely normal feeling thumb. Disadvantage are dislocation, as you can see on the right, loosening, and this is nearly always in the trapezial component. Again, as you can see on the right, this is an Electra screw-in cup which is tilted, which has caused a dislocation. These implants are expensive. And whilst using the Electra, I had 3 patients who were actually allergic to metals in the implant and they had to be removed. So what are my indications for arthroplasty? Well, it needs to be isolated trapezial metacarpal osteoarthritis with a normal scaphotrapezial joint on examination and on x-ray. I use it for high demand patients, often still in work or who have hobbies reliant on a good grip. And although I don't have an age cutoff, often they're less than 65. Because of the issues with Electra, I moved to using the Maya, and in a presentation from a French surgeon recently, he reported very nearly 100 cases with only 4 cases of loosening of the trapezial component, and all of these were within 3 years of implantation. So these results are now getting to the level that we'd be happy with if this were a hip replacement, and I think makes the use of implants more acceptable. Or if it does go wrong, well, we have a very reliable salvage procedure in that we remove the head and neck component, the cup, and then do a trapezectomy. The stem is usually solidly fixed and can be left in situ. Outcomes are similar to a primary trapezectomy. We noticed early on in our series in Swansea that males had a higher complication rate with the Electra, and we therefore moved to using a Pyrocarbon interposition arthroplasty. This is a pyro disc, which has a hole in the middle, allowing you to tunnel an FCR graft through bone tunnels and through the implant to prevent subluxation. Outcomes have been very good, and a number of patients have come back to have the other side done. So in summary, they're not for everyone. Most patients in our practice still have a trapezectomy, but for a select group of patients, I think arthroplasty is a good option. Obviously, as long as it lasts, and I think more modern implants are looking more promising in this respect. We do have a reliable salvage option. So moving on to arthrodesis, what are the advantages? Well, it gives you good grip strength and function. It's reliable once a fusion is established. It's cost effective, and it's durable. The disadvantages are that there's a significant non-union rate, quoted anywhere between 5 and 50% in various series, but often at the 10 to 15% level. There's frequent need for removal of fixation, again, quoted to up to 50% in some studies, but normally not nearly as high as that. The main concern, particularly if we're using it in younger patients, is of degenerative change in the adjacent joints, particularly the scaphotrapezial joint, but also reported in the metacarpophalangeal joint, and even the trapezoid index figure metacarpal joint. There's also the issue of reduced range of movement, which is reported in most series, particularly opposition and retroposition. Indications, again, isolated trapezial metacarpal arthritis, and really reserved for roles which require very high grip strength and durability, classically in manual labourers. So this tends to be in younger males. There's also suggestion that it's a helpful procedure when there is severe adduction of the first metacarpal preoperatively to try and present the collapse you sometimes see after a trapezectomy. There are a number of different methods of fixation. Here on the left is a plate fixation. This can be either a normal T-plate or angular stable plate. On the right, screw fixation. This is a cancella screw, but the use of headless compression screws has been described. K-wires with or without a cerclage wire, and more recently, memory staples have become popular. There are not many studies which have long-term results in large numbers of patients which describe the issues of arthritis in the adjacent joints. This publication from the Mayo Clinic in 2009 describes a large series with follow-up up to 28 years. They describe the normal sort of rate of non-unions. Grip strength was restored. Pain relief was very reliable. They saw scaphotrapezial osteoarthritis in 39 cases, which represents 31% of the patients, but at the stage they reported, only 8 of these were symptomatic. There was MP joint osteoarthritis in 16 cases, which represented 13%, but again, at the stage of reporting, none of these were symptomatic. So really, in summary, for arthrodesis, it gives you comparable pain relief and function compared to the alternatives. There are some issues with degenerative change in adjacent joints, and this is a concern when the primary indication is for its use in younger patients. Salvage options are slightly more complex and would normally need some form of excision arthroplasty to allow some movement. Really, it's a durable solution in younger working males who can tolerate a reduced range of movement. So what of my colleague, the anaesthetist? We had a long chat about different options and eventually decided that he needed full range of movements in his job. He needed good grip strength. And we felt that the most reliable solution would be a Pyrocarbon interposition arthroplasty. He's now back to full function 4 years after his surgery, and this includes playing squash. I had a chat with him last week, and he's now 4 years down the line and says he has an absolutely normal feeling and functioning thumb, and is delighted with the results. Thank you very much for your attention.